Okay, so hopefully you all should be able to see a chest CT.
Yep.
So actually, sorry, that's my second case. I'll do this one first. So this is a patient who came in to get lung cancer screening. This is his first time lung cancer screening CT. And as we scroll through, I'm going to stay in soft tissue windows for a sec. We can start to see that there's some calcifications and sort of high density along this airway in the right upper lobe. We can see that the airway gets completely opacified for a bit and almost completely calcified. As we come down to the right lower lobe, we can start to see similar finding, right? Some peripheral calcifications around the airways, extending along multiple of his airways, and sort of some soft tissue thickening as well. And so this ultimately ended up going for bronchoscopic biopsy. And they did endobronchial biopsies, both of this right upper and the right lower lobe. And it came back as tracheobronchial amyloid. So just a really nice case of not incredibly common finding, but something that we just happened to find on this patient's first lung cancer screening.
Interesting. I've only seen it limited to like a peripheral airway a couple of times. Usually it's in the trachea and it's pretty rare.
Yeah.
Did they work
I
the patient up for like, I mean, I know it can just occur as in isolation, but did they work the patient up for like a plasma cell dyscrasia or anything?
I honestly, I can't remember where they did. The
Okay.
biopsy just came back.
Okay.
They did do like a PET CT, which I have, which didn't really show much.
Okay.
Nothing anywhere was hot, so I'm sure that they are probably going to do serologic and
Mhm.
everything work up. But yeah, I think
Yeah,
this is
this
just
is
really cool.
most common. It's random. For some reason, this one is most commonly an isolated process.
Mhm.
Hmm,
Like it just falls in the airways. It's rarely associated with systemic disease.
Yeah, we have one patient in our system that has been there for years. I probably showed her imaging years ago. But hers was bad enough they actually radiated her mediastinum to get the trachea, and it seemed to put it in a remission.
Huh,
It didn't. I mean, it didn't go away, but it didn't get worse. So I don't know.
interesting.
That's actually interesting because this is invariably fatal. At least when it involves the trachea, usually they say it
Hmm,
is. So that's interesting that the radiation worked.
Yeah, and it was. I mean, it was. Yeah, it was a long
wow,
time ago. That's
interesting.
a nice case.
Cool. Yeah. And then I have one other which I would love people's thoughts on. We do actually have eventually tissue. So this is a patient who came in um, who had a couple of different symptoms. He has a remote history of smoking cigarettes. He does currently vape, and he has aortic stenosis and a chronic cough. And so he actually came to our attention because he came to get a CT for planning prior to a TAVR. And this was the CT that we got, which I'm just going to put on lung windows because that is where the finding is. And we can see these pretty impressive, very large masses or mass-like consolidation with peripheral ground glass, basically in every lobe of his lung. And they all look, I think, very similar to one another. There's a couple that are maybe a little bit smaller, but most of them are these very, very large masses.
Can you put that in
We had,
soft tissue window real quickly?
yeah, of course.
Yeah. Not fat.
Yeah, they're not fat density.
Very low
Um,
attenuation though.
mhm, yeah. So I would love to hear what people's differential for this would be, because it just seemed a little bit unusual that these were so sort of very similar to one another and kind of everywhere.
Mucinous adenocarcinoma, although it's
Mhm.
not the most typical. Usually they're shaggier looking with some satellite.
Yeah,
The reason I was asking about the soft tissue density because yeah, it looked low. I was thinking fat,
right.
but
Yeah,
that doesn't
Can
look.
you show the lung windows again?
yeah, of course.
Or
And
I was kind
Yeah,
of looking at
yeah.
something
I
else.
also have a PET CT of it too that I can.
yeah, malt lymphoma would be
I
another.
was gonna say, yeah,
Yeah,
I was gonna go lymphoma on this.
Yeah,
I think that was sort
That
of the
was
highest on our differential was
Yeah,
lymphoma,
more
some
so than
sort.
adenocarcinoma, like Jeff was saying, also that you often see nodules from the erogenous spread of, yeah,
Hmm.
in the pet.
Yeah, and so
Doesn't
they're
really change any of that, I don't think.
No,
right. And I guess possibly
but
interestingly for in a minute, there was nothing else on the PET that was hot. So
all my
I
best.
ended up biopsying
yeah,
this
that
last
was my
week.
thought when it popped up was lymphoma.
Yeah. So I did a biopsy this last week, and it actually turned out to be mucinous adenocarcinoma. I biopsied this one up here.
Oh, was adenocarcinoma?
Yeah, which I thought was a little bit weird. And, they diffed it as probably lung primary, but could be GI primary mucinous.
Yeah, that's
So I wonder whether these are like, yeah, it's so weird that there's so many of them and they're sort of all kind of seem like they're at the same stage and they're not directly spreading from one area. Like, again, like you said, there's not a lot of nodules or sort of clear, distinct connection between each of these.
Was there a
But yeah,
smoking history at all? Do you know?
yeah, there was. He had I think it was like a 50-pack year, but quit 45 years ago. But he was currently vaping. I think not tobacco though. So yeah. Anyways, weird presentation
Great case.
of multiple
Yeah.
adenodes.
That is
Yeah,
a weird.
thank you.
I mean, that is a weird one
Right?
because this is not a rod, and this is not through the airways. I mean, this
Exactly.
is weird.
So like presumably these are maybe all separate primaries at the same time.
I have a hard time with that because
Yeah, I
Yeah.
agree.
I mean, they look exactly the same.
They look exactly the same. Yeah. So I wonder whether I mean, I don't know.
But
There was
one,
nothing else that
yeah,
was
it's
hot.
just a
So
weird
again,
one.
probably less likely Mets, but yeah.
Well, if they send it for any other, yeah,
Yeah, I think we just got this back. I'll definitely follow up if we get more data on it.
well, very
But yeah,
cool.
those are my cases.
Thanks. All right, let's
Thank
see.
you.
Seth or Travis or Peter?
I can go. It's been
Oh.
a little while.
All right, let me
There we go.
stop sharing.
I guess I'll show this case because I have it up. Oh, I did have it up until it just disappeared because I clicked on something. So this is a patient with a supercritical VSD, outflow tract VSD. Now that's not that interesting. But what is interesting is, so the study I read, so I read both the MR and the CT. I forgot about reading the MR, just happened to read a CT. Now, well, sorry guys, 1 second. So you can see here, it's a relatively small defect, and there is left to right flow like you see in most VSDs, and this was a long-standing shunt. The patient also had severe pulmonary hypertension, but the patient had quite bad lungs. You know, there may be other causes of pulmonary hypertension here. Plus, the patient also has a very dysplastic pulmonary valve. But what was interesting is on this study, so remember that our MRs, at least the 40 flow, it's a respiratory gated, and like most things in MR, it is gated for towards end expiration. And this is the CT, which is acquired during inspiration. Whereas on the MRI, you're seeing left to right flow. On the CT, which is acquired during inspiration, which is obviously going to increase right-sided return and increase right heart pressures, you actually see reverse flow. So I thought this was just a cool physiologic thing that they can see on echo without an issue because they can acquire it during the respiratory cycle, and they do. But I thought this was neat to see the two modalities. And I actually have, you can see the little jet. I'm sure people can see it, but I'll back it up. You can see the jet, the defect here, and then the jet of white contrast from the RV going across here. And we also randomly have an outside CT from before, from an outside place, not the best study, but also this was acquired at expiration based on, you can just look at the trachea and the bronchi here and see that this guy is at expiration. And on this expiratory study, again, I won't beleaguer the point, but because it's not the most beautiful study, but on the expiratory study, there is holosystolic left to right flow. So I just thought that was kind of neat to see the variation in flow across these different studies depending on the yeah, you can, anyways, if I won't waste people's time, but it's dose modulated, but there are a couple phases here you can clearly see flow across. Anyways, Okay,
Is it just
maybe.
the respiratory, or is it like, because it looked like it was kind of to and fro flow, that some of it was a like a lower attenuation contrast jet back to the right. And
On
some of
which one?
on the first study you showed the better quality.
The CT?
Yeah, the CT.
Yeah, it was going back and forth, but the majority of it was to the right. But no, it was a little bit going back and forth. But it was switching directions based on yeah, but you're right. Based on the
That's really cool.
So anyways, here you can see it just spurting across on this CT, just going from left to right here, and the other one was more right to left. Anyways, physiology in action. I guess that's always interesting. This is one of those cases itself is not, and I couldn't find, because I still haven't seen a case. It's interesting, but this is a patient with lupus, and whenever I see a patient with lupus and a prosthetic mitral valve and a young patient, I always get, a little excited that maybe we have an echo or some old study here, because, most of these, you don't often get bioprosthetic mitral valves in young patients. I mean, she didn't have like prolapse or anything. So she came in, and the reason she came in is she had hemoptysis and had DAH, which itself is kind of interesting. But the other interesting thing is that she had a couple weeks before or a couple months before, had a massive stroke. Again, I'm not a neuro guy, but that's a big area of stroke. And there are a bunch of areas of other stuff in the cerebellum. And on her, of course, so they were looking for an embolic source, and they did find an embolic source on the mitral valve. And, it's one of these things that we hear about. I've only seen one case that had it proven, but this was a non-infectious endocarditis in a lupus patient. So this patient had Lehman-Sachs, which was proven at the outside hospital when they took out her valve. So it was a non-infected vegetation that embolized. So I wish I had because I still haven't, I've seen a couple cases of post Lehman-Sachs with the valves. I just never seen a case de novo. And I was hoping with that one I would actually see the case. This was a very good pickup on a radiograph by one of our faculty. This is not a radiograph, this is the CT, which shows this nasty mass eating into two contiguous ribs and into the vertebral bodies, and you can see it here. So again, a very good pickup on radiograph to see this on a PA and lateral at the superior margin, given all the noise. So then she didn't really have anything else much, maybe a couple pulmonary nodules, but nothing too impressive. She also had a lot of other symptoms, so underwent a full spine MR, and you can see there's other lesions in the spine. Additionally, let me go to the other sequence. Yeah. All right, you're not going to load. Anyways, there were lesions everywhere. They're not only in her spine, but also had this epidural component, had components in the soft tissues, and this was actually disseminated cocci. So disseminated cocci with extensive spinous involvement and involvement of the soft tissues and involvement of the central canal. I don't know. I was surprised by that.
We've seen a lot of these disseminated cocci cases thanks to you guys on the West Coast, and I get the sense it frequently looks like TB.
It does look a lot like TB, and I have seen cases of disseminated TB that do this.
Right.
I just had not seen one with, and it makes sense that you can get with both, but I just hadn't seen one.
Right. But we've seen like peritonitis. We've seen we've seen it mimic cancer. We've seen cavitary cocci. We've seen miliary cocci. We've seen soft.
Yes.
And
Yeah.
blastomycosis can go to other tissues, but it tends to, because it's interesting, it just tends not to. It's rare to see it without any lung involvement. Whereas cocci, we seem to see cases that don't involve lung, or at least when by the time they present.
The last one I have a nuke med study on, but I won't show it because I can't get the HIPAA stuff off the nuke med studies. This is a patient who, this is her study from 2013, and she had an outside study. You can see the PAs are small, distal main, left and right, no real abnormality otherwise. The VQ scan that she had recently showed perfusion defects that were thought to be CTEPH, so they sent her for a CTEPH CT, and then subsequently we got the outside studies, and now you can see that there is this very abnormal soft tissue surrounding the main PAs that are markedly narrowed, and you can see how small this gets here, just almost gets obliterated, and the main PA is also quite narrowed, and as is the right PA proximally, a little more narrow than it was before. No embolic disease, and so it's going to be some form of vasculitis. She has nothing else involved, so it was more of a diffusely low uptake in the left side than a clear knocked out. If you looked at the VQ scan, it was just very subtly gray in the left lung, whereas there were a few areas of abnormality in the right lung. Anyways, the VQ scan was more impressive than the dual energy. But yeah, that was just a case of, we're presuming, again, everything gets labeled Takayasu's when it's in a young patient, but presuming some sort of vasculitis involving the pulmonary arteries in this patient. She also incidentally has a interarterial right, but those are usually benign anyways, even though that's not what we're taught. We're taught they're, they should be worked up, but usually don't lead to any issues. Yep, that's what I got.
Awesome, thanks. All right, who'd like to go next?
I can go.
All right.
So I have a collection of 3 related cases, and 2 of these are old. One of them is newer, which is what prompted me to dig up the old ones, because I don't think I've ever shown them before. And I think these are like often the pitfall of pulmonary embolism studies. This one, not really a diagnostic dilemma, even though this was not seen at an outside institution. This is not the recent one. But I always get nervous when the timing is too good in the pulmonary arteries, and you always have to ask yourself why. And certainly, if you see little contrast in the aorta, it could be that you're just timing, doing bolus tracking, or just timing without much of a delay, or it could just be that it's slow outflow. And in this case, you can see there's a dissection flap involving the aorta. And I think the reason here, the LV is a little dilated, and he had some issues with aortic valve incompetence because of the dissection flap. But there's multiple things here to clue you into the presence of the dissection, even though it wasn't seen. I think this is a huge aorta. Oh, why is it not showing? Let's see. Well, I don't know why I can't get a size on it, but you can see it's like double the size of the descending thoracic aorta. And his lungs, I think also people just see this stuff and say, oh, it must be infection or something, but this is just acute edema from his incompetent aortic valve and struggling left ventricle. They repeated this one, when he was referred, and you can see the extent of the dissection flap. And I think here you can see it's prolapsing into the aortic, into the left ventricular outflow tract. So this was, it's visible and should hopefully be seen. This next one, exact same thing, except a little bit earlier timing. And here, this one's a little bit more subtle, but you can see the early contrast in the true lumen and much less in the excluded false lumen. This one was also overlooked. Now, I guess my question for you, and I know Jeff and I have talked about this before, is timing of PE studies. And I think you were saying, do you time all of yours off the left atrium?
Yep.
Yeah, and I think there are a lot of places that still don't do that. I'm a big advocate of it just for this very reason, that it's easy to miss stuff on the left side if you don't have adequate concentration of contrast. But this was another one. And then I saved this. This is an older case that I couldn't show for a while, but I think this is the most interesting one of all. And I think, so here's, I'll just show you, this is so they did a timing bolus. And I think that actually comes into play on what we see here. Just the fact that there's a little bit of contrast on board. So here, there is almost zero contrast in the left heart. There's, at least in the left ventricle and in the aorta. There's some getting back into the pulmonary veins and into the left atrium. But the thoracic aorta, you can see there's a little bit of, of loss of definition of fat plane along the proximal descending aorta here. But the kicker is, look at this, only visible at the level of the abdominal aorta is the dissection. And I think this must be some of the contrast from the timing bolus, because you cannot see any dissection flap earlier up. And moreover, there's just no contrast here. But this is, and I don't have follow-up imaging on this, but this patient had a leaking dissection here and actually passed from from a rupture in hemothorax. But have you guys ever seen a case like this though?
No.
I can't think of any other reason why you're just seeing the contrast here other than it was from that timing bolus that's just hanging around.
Yeah,
So,
it also depends on, some people scan bottom up, some people scan top down too.
yeah, that's true. But
But I bet it's just leftover from the timing.
yeah, but I don't know. I think people reflexively jump to PE studies for any symptom in the thorax.
Mm-hmm.
And I don't know what it's interesting because I think UCSF was the same as Duke. It depends on who the attending is in the ED, because some nights we'll get a dozen dissections ordered and then the next night it'll be a dozen PE studies ordered, and it's whatever they choose is their flavor of the day.
Our PE is sort of our de facto double rule out. And actually, it's funny, I had a case this week of it was a PE study. It was like chest pain, rule out everything. And the patient ended up having a type A dissection, and we would have missed it had we not done the way we do our PE studies, where we time off the left atrium, because there was no we don't, it was mostly, I don't know, maybe we would have seen it was mostly IMH with a small intramural contrast collection. But yeah, that's kind of the reason we do it, because I think from a clinical standpoint, it can be hard to tell the two apart, and especially when you have emergency medicine physicians who've trained in an era of CT at their fingertips. They, which one to order, and if they're trying to tease out which one it is. So I don't know. I'm glad we do that. We've had a couple. We've had some temporary techs or new techs, and sometimes they forget. And it's interesting because they say where they used to work or where they trained, it's always timing off the pulmonary artery. And I think with the faster scanners, there's no reason you need to do that. All right. Let's see, Peter, or let's see, Shrav is on. David.
I got some cases.
All right, because we should have time for everybody today.
I don't have anything today, Jeff.
That's all right.
Okay, can you all see my screen?
Yep.
Okay, so you can probably guess what this or what we're going to see on the CT, but here's a chest radiograph. We've got that kind of reverse 3 sign here. So this patient had a repaired coarctation, and if we take a look here, we've got so this patient also this is like a fairly young male, and had congenital bicuspid aortic valve and aortopathy, developed a type A dissection, which was repaired with this modified Bentall procedure. And so he's got the aortic valve prosthesis here, and then ascending aortic graft, and also coarctation that was also repaired, and the stent looks patent. One of the interesting things here is, whenever patients have endografts for aneurysm dissection, whatever, we look for endoleaks, and so here he's got these collaterals that are resulting in opacification of the excluded portion of the false lumen here. So he's got a type 2 endoleak, multiple little collaterals coming off of there. Some of them are really dilated, or focally dilated, kind of tortuous up here in the mediastinum. And so that's that case. We'll go to the next.
Wait, you said a false lumen, or is it just the end of the stent for the cohort?
It's not, because the end of the stent is down here. We see a little, maybe a fold or a dissection flap. But then if we come up here, the stent kind of bridges this whole area. And so it's contrast opacification out here, where you're not supposed to see opacification. And then if we want to take a look on the coronal, here we go. Got some little tortuous collaterals here. So the next case is this patient. So if we take a look, scrolling through the CT, we see this kind of basilar predominant ground glass opacities, pretty geographic, sharp margins here. Not that it's really specific for anything, but this patient, the history is more interesting. So she underwent CAR T-cell therapy, and so CAR T-cell therapy, basically you can get these T cells to kind of target certain proteins or certain antigens that are overexpressed on cancer cells. And so this patient had ovarian cancer, and one of the cancers that overexpresses a protein called mesothelin is ovarian cancer. Other cancers include pancreatic, lung, and mesothelioma. But so her CAR T cell was kind of targeted towards mesothelin, and she received it, and within a couple of days developed this basilar predominant ground glass opacity. So this is CAR T cell pneumonitis. Is it possible that maybe she had some other, got COVID as well? Not sure. But we see all this basilar predominant ground glass opacities, interlobular thickening, maybe some interstitial thickening. It's hard to say with all of this motion artifact, but that's it. Have you seen a lot of these? Has anybody else seen a lot of these cases?
I have not.
And I wonder, one thing I'm curious to, if anybody's seen any of these cases, is what's the between the therapy initiation and time of onset of these opacities? Because this is like the first case I've seen.
Well, David, do you know, since the Fred Hutch probably pioneered a lot of this treatment?
No, I don't know, and I think it probably depends on the specific antigens that they're going for. So I'm not aware, I've not seen these cases before of ovarian cancer treated with CAR T cells. I'm used to seeing, lymphocytes in leukemias and lymphomas being targeted, but not this ovarian cancer. So I have no idea. So are you telling me that lung cells have expressed mesothelin, or is it just the pleura?
Well, so I'm not sure whether lung cells express mesothelin, but if you can treat lung cancer with this mesothelin targeted CAR T cell therapy, I wonder if there is some cross reactivity with normal lung tissue.
I will
That's
ask
kind of my guess.
I'll get back to you if Colin has any insight into this. So
Cool.
let me ask.
Okay. So then moving on to the next case here. This is so if we take a look at the trachea, this person kind of has what I like to call a lemon-shaped trachea. And so they have trachea bronchomalacia. And one of the interesting findings in this patient is we happen to get a dynamic expiratory scan or exhalation scan. And so here we see collapse of the trachea in the AP dimension. And we also see a lot of air trapping throughout the lungs. And one of the things that there's been some discussion in the literature, people have thought that maybe this is due to chronic small airways inflammation related to impaired clearance of secretions and other stuff that's some infectious material in the lungs. And some people think maybe it has something to do with deficient cartilage in the bronchial walls out here. So before you get to the bronchioles, which have no cartilage in the walls. And so I guess, is there a consensus as to what this is, what is the underlying cause, or is it kind of up in the air?
Right. It may be variable. I think it's sort of an end result from different issues, whether it's cartilage, smooth muscle, elastin fibers.
Mm-hmm.
That's the way I think about it. It's like, it's like tracheomegaly, right? It's Meunier-Kuhn syndrome type phenotype. You see it with a variety of things at different ages. And
Yeah.
so I think it's just you injure the airway is not normal, and from whatever stress or insult to it, it's just how it ends up. Sort of like the lungs only have a certain way they can respond to things.
Okay. Sounds good. And so the final case here, this is just a cool case. So this patient underwent cardiac MRI for, well, I'll show you the cardiac MRI. That's a little more fun here. So can you still hear me?
Yep.
Okay. So here we see this is a giant mobile mass in the right atrium kind of prolapsing into the right ventricle. And if we take a look, we can actually see that there's something kind of moving around here in the inferior vena cava. So if we look on the LGE sequences, we see that there's some internal enhancement in this lesion. And take a look at the CT. Here it is. Distending the inferior vena cava, and then if we take a look at the abdominal CT, it kind of extends all the way down through the IVC. And so this patient had a slow-growing endometrial stromal neoplasm was the histology. And so that had kind of invaded into the IVC and extended all the way into the right atrium. And I just thought I've never seen anything that large.
Wow. Were there any lung mets?
Fun case. Huh?
Were there any lung mets?
There were a couple of lung nodules.
It's one of the tumors that can give you cystic metastases too.
Yeah, I don't think I saw any cystic lesions, but there were a couple of solid nodules in the bases.
Nice.
Cool. That's all I have.
All right, thanks. David, do you have anything?
Not this week. I'm stranded on my laptop with my main computer not working. So
Not a problem. Okay, I can show. We just have a few cases. All right. I can't remember if I showed this case, so stop me if I have. So this is a young woman with bad pulmonary hypertension and a diagnosis of hereditary hemorrhagic telangiectasia. And this is her CT scan, and it's quite interesting. I love people's thoughts on it. So you can see she's got lots of tortuous looking vessels. This was an area of presumed hemorrhage. These sort of central lobular ground glass opacities. I'll show you her soft tissues. You can see she's got severe RV hypertrophy, right atrial enlargement, flattening of the septum here, dilated pulmonary arteries. So bad pH. And the question is, or the comment, or both, is, we see AVMs, and I suspect this thing up here is probably an AVM. It's sometimes hard to follow all these rat's nests of vessels, but some of these look more like almost some transpleural collaterals, or trying to be, or like something like this. I couldn't hook every one of them up, and you see how this one runs along the pleural surface. I don't see big intercostals, though. That's the only thing. Or if these are just like telangiectatic vessels, but they're not actually AVMs. Because usually when I see AVMs, I often see areas of black lung around them because it bypasses the capillary bed. But you can see this is almost like what you see with hepatopulmonary syndrome sometimes. I don't believe she had liver involvement. But have you ever seen this with HHT?
No, I mean, it looks more like a PAH. I mean, the lungs look more like PAH.
So
That
could it
kind
be
of,
that just she has bad pulmonary hypertension, and this is not the HHT itself, but from her pulmonary hypertension, and she just happens
well,
to,
right.
yeah,
I mean, she clearly has HH. I mean, she clearly has AVMs, but I mean, I've seen a fair amount of cases of HHT. I've never seen this, even with worse, more numerous clear AVMs. I've
Mhm.
never seen this, what looks like PAH looking lungs with these kind of periarterial or ground glass
Right,
blushing. I've just not
right.
seen that. I
Yeah,
mean, it could be all, who knows, but
yeah, and her pH is really bad. I mean, she's being considered for transplant. It's that bad. So yeah,
yeah,
I think that's a good point, because it looks like some of the long-standing pHs I've seen are the severe ones. So
yeah, exactly. And I mean, but the AVMs are very interesting, and I don't know. You may be right. I mean, it may be a combination. The stuff peripherally could be a combination of both AVMs and sequela of long-standing severe pulmonary hypertension.
okay, all right. This is a patient. This is a young patient, 24, presented short of breath, and you can see there's this large mediastinal mass, pleural effusion on the lateral. It's primarily prevascular here. So in a young patient, we'd think, of course, lymphoma, maybe an ugly germ cell tumor. Um, so they got a CT scan, and you can see there's this just homogeneous infiltrating soft tissue, predominantly in the prevascular mediastinum. It's encasing the internal mammaries. It's acting like a soft tumor. You can see the cavus patent, small but there. So normally in an adult patient, this would be a diffuse large B cell lymphoma. Um, and this is lymphoma, but it's not a B cell lymphoma. So they actually biopsied this, and it's a T lymphoblastic lymphoma, which usually occurs in kids. So it's an unusual tumor. I mean, I guess it's a young adult, but it's an unusual tumor to present at this age, um, in this location. But a really nice example of pretty typical mediastinal lymphoma. Um, I wouldn't have thought Hodgkin just because of the homogeneity of it in discrete one big blob mass. And then I don't have the follow-up imaging on here, but yeah, the patient responded quite quickly to some treatment on the follow-up radiographs. The mediastinal mass had gotten a lot smaller. But yeah, if you do peds or see really, really young adults, that's more often what they have, is that T lymphoblastic lymphoma. And then this is kind of an odd case because I can't figure out where it's coming from. The imaging isn't terribly exciting, but this patient, I can't remember why they had a CT scan, but they had all of these nodules. They're solid, well-defined, randomly distributed. And of course, and some of them are funny. Some of them are more like elongated, but most of them are just typical nodules. And thought was metastases, maybe fungal infection, like a multifocal histo or something like that. But the patient didn't have any symptoms. So one of these was biopsied, and this came back as epithelioid meningoepithelioma, or what do they call it, meningoendothelioma, which is
New meningoendothelial like nodules.
no, I'm an epithelioid. Um, it's the old
Hemangioma.
perisarcoma. I can't say it. Here, I'll go back to, I'll turn off, I'll unhide it. I wrote
Epithelioid hemangioendotheliomas.
Hemangioendothelioma, yeah, that's right.
Okay, so
Yeah,
that's like it's like a low-grade angiosarcoma. It's like an intermediate between an angiosarcoma and a hemangioma.
yes, yes. So it's a vascular tumor, and a lot of times they start in the liver. But this one, there's no extrathoracic disease, and it just present. I mean, these were instantly detected nodules, um, and
That's random.
yeah, it is. Howard, I know, shown a few cases, and when I looked it up, there's a lot about ones in the liver, but I mean, it can, in theory, occur everywhere. I mean, this looks like metastases, but I don't know where, if it's just a multi-center tumor, because there's no dominant nodule, no dominant mass. Unfortunately, there's not a lot of great treatments for it, but it can also progress slowly as well. But yeah, so an unusual cause of random nodules in an unsuspected case here. All right, well, that is all I have. I left my thumb drive at work, so I don't have my but anyway, thanks everyone for all the good cases. I think we got through everybody. Unless there's anyone else who has some extra cases they wanted to show. All right, well, we'll just call it a day, and I will talk to you all next week.
Thank you.
Thanks.
Thank you all.
Bye, everyone.